All right. So like the title suggests, we're going to be focusing on non-invasive strategies for treating migraine. And, maybe instead of looking at pills or injections, other types of devices and tools that you can use as part of your treatment plan. Like Ashley hinted at, again, we're just providing information. And so even though if it may seem from my presentation, it's a good fit for you, I think it's still important to have that discussion with your healthcare provider because there may be some other reason to think twice. So let me just advance this here. It's freezing on me. There we go. All right, so this is me. I'm a neurologist and I did my training at Queen's for medical school. I did some time at Western University for neurology. And then I did a fellowship with Dr. LaRue Muzagar-Becker over in Calgary. Right now I operate a community-based headache and neurology practice in London, Ontario. I'm still doing some research. So right now I wrapped up a cannabis study for migraine and we're looking at now perhaps some psilocybin-related trials to migraine and other headache-related disorders, as well as education-based research. And we're focusing on curricular content for the residency programs. It's a big project of ours to try to increase more neurologists who are aware of these kind of things. So for my disclosures, just so you're aware, my fellowship was funded from the Canadian Headache Society. And I participated in ad boards for various pharmaceutical companies that help to deliver migraine medications. Novartis, Lilly, Lundbeck, AbbVie, and Teva. Similarly, I give a lot of talks to family doctors, nurse practitioners, other people in the community, just to help spread it. And we've been lucky enough to have some funding to assist with that. So for tonight, what I want to focus on is just reviewing the neurostimulators that we have available here in Canada to people who suffer with headache. We're going to look over some of the purported mechanisms. A lot is still pretty mysterious about neurology. I tell people we're really good at telling people what things aren't, ruling things out. But there's still a lot of mysterious stuff between neurology and psychiatry. And migraine and some of the other disorders are something that fall into that gray zone. We're going to look at some of the landmark studies for these stimulators, and give you a relative idea of, a reasonable expectation of what you can expect from using them. For the physicians in the audience, I hope that you're better able to, pick out maybe the patients that might be a good ideal candidate for these and think about it when you offer them some choice in the clinic. And for patients, at least you'll have something to take back to your headache provider and maybe come up with some alternative options if you're reaching some difficulty. So I think a good place to start is looking at the current landscape, of headache. Maybe some of these numbers are a little bit older, but I think a good rule of thumb is that maybe 1 in 5 Canadians will suffer from, a primary headache, specifically migraine, at some point in their life. There's over 1 billion people in the world who have migraine. In about 50% of these patients, there's more than a 5-year delay between the first time that they manifest a migraine, looking back, and when they finally get that label from a provider. And so many people go for many years not even knowing it's a migraine. Now you've reached the hurdle of getting the diagnosis. About 30% of the people who qualify and should be having a preventive actually receive it. And then even worse, at 1 year, fewer than 20% of these people are still taking their preventive medicines more than 80% of days. And I think that speaks a lot to, a lot of the medicines that we traditionally use for migraine, because they have some pretty bizarre side effects, or, it's just not practical for some people to take, a pill every day. So I think it just kind of speaks to a need for alternative options for these people. And so that's where this kind of comes in. Sometimes pills aren't an option. People are kind of fed up. So I've overheard in the clinic, I prefer to take a natural approach. I want to focus on vitamins and lifestyle. And I think that's reasonable to start. People are tired of experimenting with medications. They often joke that they're my test subject or guinea pig. I try to tell them I'm not doing tests on you, but it is a trial and error process, and that can be very frustrating for people. Some people just don't like the way that medications make them feel. There's always the crowd where they feel that all medicines are, my body resists them and I don't, do well on these. And I want to caution some of these patients too, because, we all know about the placebo, which is you can have a positive effect just by expecting good results. But the flip side of that coin is the nocebo, and so sometimes if you're reading the monograph where you expect medicines to fail, you can sometimes, undercut your benefit sometimes too. So it's a double-edged sword. The other thing is, the multiple chemical sensitivities and things like this, where they've really tried a lot of medicines and gave a fair effort, but it just doesn't seem to be a fit for them. So they're looking for options that aren't systemically absorbed, either things like injections, whether it's Botox or a nerve block, or maybe other things like a stimulator. So a quick overview of the neuromodulatory approaches to headache to date. From left to right, you've got things that are acting more centrally, like a deep brain stimulator, where they actually insert a platinum cathode deep into centers in the brain and send electrical pulses. You've got things where they kind of just sit just under the skull cap, under the lining of the brain, and they're sitting right on the surface. That's a cortex stimulator. Sometimes we target things in the spinal cord or at the occipital nerves, which are the peripheral nerve stimulators. And there are other types of unusual ones, for sphenopalatine ganglion. But these ones, I would say, they're reserved for patients with the most severe disability who have tried everything. It's very difficult to find subspecialty expertise in neurosurgery and people who are willing to do these things. So often patients may face barriers like having to travel very long distances. And they suffer from a lot of complications. There can be bleeding, infection, migration of the leads. So, these are not things to be considered lightly. For the purposes of our talk here today, we're going to focus on the non-invasive stimulators. And what's nice about these is that, some of them are even available without a prescription, and they're available to people, in the community without having to go to a tertiary medical center. So I think that's kind of exciting. So focusing on Canada, I would say here are kind of the four big ones that we think about. There's been an explosion of devices, more recently, and a lot of them are in the States. In Canada, I think we have two main ones, and we're going to focus on these for tonight. The first is Cefaly, which is a type of external trigeminal nerve stimulation device, and that's working on branches of UV1. And then the second is the gammaCore, which some of you may be familiar with, and this is a non-invasive vagal nerve stimulator. The other ones, Nervio and eNeura, unfortunately, are not available in Canada, but we'll take a quick peek at them just so you're aware of what's brewing. So this is Cefaly. And you can see the device is attached to his forehead by a little adhesive patch there. And so it's called the Cefaly Dual because it has kind of two programs that you can use it for. It's a transcutaneous nerve stimulator, like I mentioned. So it's sending little electrical pulses, kind of like a TENS machine. And it's hitting those two branches of nerves here on your forehead. It's the first device of its kind that was approved by the FDA for the treatment of migraine. And like I mentioned, it's the dual because it's got two paradigms. You can use it both as an acute medication, which is on demand as you need it when pain is bad, and also as a preventive. So you can actually use it in a way every day to try to prevent headaches from happening. So for acute, it's indicated in patients 18 plus, migraine with or without aura. And you can use it, 60 to 120 minutes. So studies looked at both paradigms, and maybe it's a little bit better with a prolonged application, but then you have to deal with paresthesias for 2 hours as well. Preventive treatment, which is kind of nice, also in episodic migraine patients 18 plus, and this is for people taking it maybe 20 minutes each evening, but you could probably do it at different times of day. It's available over the counter without a prescription, which is nice because it's a little bit easier to obtain. And so we talked about the acute treatment. It's a higher frequency and longer stimulation period compared to some of its, competitors. But the way we think this works is by exhausting pain signals in the fibers. So, these nerves communicate with different chemicals called neurotransmitters, and you can actually use some of it up. That's called tachyphylaxis, and it takes some time to regenerate. So it may be working through that way. I think the studies have touted pain freedom, pain relief, maybe not complete absence, but it's better, and resolution of the most bothersome symptom, which could be like photophobia, the sensitivity to light, nausea, or vertigo or something. So I think we'll take a closer look rather at the data for that in a second. The preventive option, 20 minutes each evening or morning, like I mentioned, it's a lower frequency and it's something you do on a daily basis. And instead of just kind of hammering the nerve, for a long time to try to deplete the signal, they're thinking maybe this is working indirectly through some both peripheral and central mechanisms to change the way the migraines happen and the threshold. The studies for this one showed some reduction in migraine days, any kind of headache days. So, you don't necessarily have all the features of a migraine, and also showed over time to reduce the use of acute medications. So safety and contraindications, important to point out, compared to something like topiramate or other oral medications, no serious adverse events in the trials. Mild adverse events were things like sleepiness, fatigue, insomnia, local pain and paresthesia, maybe worsening of headache. But in general, it's pretty well tolerated. The people who definitely should not use this are people who have metallic implants in their head, cochlear implants, plates, any kind of stimulator that's already embedded, and anybody with kind of cardiac implanted lines or pacemakers. So how does it work? You got to make sure that you clean your forehead every time, whether that's like nicely with soap and water or they've got wipes that come along with this. And then you can see this lady here, she's applying the patch to her forehead. You kind of want to center it there in the glabella. And then you're going to make sure it's firmly attached by rubbing your fingers over it. And then embedded in that patch is actually a little magnet, and that's where the Cefaly itself attaches. And then you can program the device and you can use that power button to get it started, and you leave it in place. So attaches using the self-adhesive electrode. Each electrode is actually designed to last for about 20 applications. So, you do end up having to replace them. So there's a little bit of a cost with ongoing use, but it's pretty reasonable given that you can reuse it so many times. So how does it work? Okay, so you can see the woman here, she's, attached it to her head. It seems to be pulsing. So these stimulate both supraorbital and supratrochlear nerves. You can see some of the depiction of this in the middle here. And these feed back through V1, which is, the first division of the trigeminal nerve, the ophthalmic. It goes all the way back through various holes in your skull, feeds back into the brainstem, into the trigeminal nucleus caudalis, which is the kind of generator of migraine. This thing integrates the 3 branches of your trigeminal nerve from your face. It does auriculotemporal nerve from the sides, occipital nerves, and even upper cervical roots. So all these kind of sensory inputs are feeding back into this area where migraine happens. And, chronic pain from there can bleed both ways. So that's why people often have neck stiffness, pain in the face, all over the headache and migraine. So it's feeding back to the brainstem. And there it causes changes both in peripheral nerves as it goes along, but also in brainstem pain centers where the migraine resides. And then over time, it even causes central changes. So this is going to be the change in the pain and salience matrices that are involved in the pain dysregulation. That's a little bit beyond the scope of our talk tonight. I don't think we have enough time to get into it, but I will, just for the sake of interest, go over a couple interesting points. I think the truth is that we don't fully understand even the full mechanism of migraine. We've made a lot of interesting advances recently, and the mechanism by which these stimulators work is even more mysterious, to be honest. But there are some important clues, I think, that are very exciting areas to continue researching. First is that, external transcutaneous stimulation, it changes that trigeminal nucleus, and it changes the threshold to alter the pain response. When we look at FDG PET studies, you may see some of these colorful brain scans with different areas that are lighting up different colors. Migraineurs tend to have less metabolism in the frontal temporal area compared to healthy controls with no headaches. And you can actually see normalization of this over time with chronic use of the preventive. Another type of imaging, which is bold, and it looks like when we have people do tasks in the MRI, their brain uses amounts of sugar differently and extracts oxygen differently. And so as a result, we can try to see what are the areas of the brain that are active when you're doing a different task. And so for migraineurs, when we actually stimulate them with a heat, like a painful stimulus called a noxious stimulus, they light up in a particular way that's different from healthy controls. And they have much greater reaction. And when we use eTNS, the nerve stimulator, it actually kind of returns that closer to normal compared to healthy controls. So it suggests that we're kind of shifting the brain to behave a lot more like someone who doesn't have headaches. And another interesting one is this idea of thalamocortical reverberations. So the thalamus are like these 2 things sitting in the middle of your brain, atop the brainstem, and they're essentially the relay station for everything in your brain. So they go back and forth from spinal cord to the cortex to the deep gray structures. Very, very complicated circuitry. But what's interesting is that there's many loops that go back and forth to the cortex. And we think that it stores different types of sensory memory. There's all sorts of information that reverberates there. In people with migraine, we're able to kind of normalize the function of those reverberations. So it's almost like maybe perhaps you're trapped in a sensory loop of pain or something. And by repetitively stimulating you and kind of coursing your brain and returning to a normal pattern, perhaps we can get rid of those dysfunctional rhythms. And so that can be seen in something called the somatosensory evoked potential. If we're doing this talk maybe in a more academic setting, we can go through all the evidence piece by piece, and it's kind of exciting to parse. But for the interest of time, I don't think we can do tonight. So let's take a peek at the first study, and this one is called ACME, and it's looking at acute data for 60 minutes of stimulation. And so this was prospective, double-blind, randomized, sham-controlled study. People were given little units that looked identical, but maybe the pulse strength and width and frequency is lesser than the stimulator. And so this was an American-based study, and it recruited 106 people. They were divided 1-to-1 to have verum, which means like the true treatment, versus the sham, which is kind of the fake one that's not as powerful. And so they recorded their pain scales using the visual analog, and they were recorded at baseline before they started. Then after 1 hour, 2 hour, and 24 hours. So to get into the study, you could be male or female, anyone from the age 18 to 65. You had to have a diagnosis of migraine with or without aura. And then you had to experience an attack with or without aura lasting at least 3 hours. They wanted to make sure it wasn't just a brief attack or a false alarm. And they wanted to see that the pain severity was essentially stable for about an hour prior to enrollment. So, a little bit specific, but I think it's good to try to narrow down your population to make sure you can detect a signal. What was nice about this is that it included both episodic and chronic migraineurs. And if you're keeping a pulse on the evolution of our research, I think we're trying to move away from the episodic and chronic paradigm because perhaps it isn't as relevant. People that were excluded included those who were pregnant, people who've had Botox or supraorbital nerve blocks, if they had other types of headache other than medication overuse or migraine. And so, again, it's important to make sure that we're getting a good sample for the study to see that it works. You don't want to confound it with too many other variables. But also sometimes, if you're too stringent, it can limit the generalizability to your population. So what did they look for? They were concerned with pain intensity at 1 hour compared to baseline as a major thing. The other key kind of secondary endpoints to look at were things like pain freedom at 1 hour, change in the intensity of pain at 2 hours, intensity of pain at 24 hours. So they wanted to make sure that this was a sustained benefit, not just like, it's helping for a little while and it's masking the symptoms. And then they also looked at how many times patients had to use rescue medication in addition to the stimulator compared to baseline. So what they found, there was a significant difference, looking at 59% reduction in pain intensity at 1 hour compared to the sham. And this was found to be statistically significant, more than double. Of note, if you're familiar with the trial data for migraine, look at the size of the placebo. 30% is pretty huge. And this is actually, standard for a lot of pain medications and stimulators. And, I think that just goes to show, I think sometimes people don't understand what placebo is. And it's not that it's fake. I think it's a very powerful response, and it shows kind of the higher cortical centers that are involved in pain processing. So, the power of your expectation, these things are impacted by anxiety, mood, all these things. And so it's important not to neglect that. But I think this is clearly it's demonstrating a superiority over placebo for sure. So looking at their data over time, this is looking at the severity again. And there's a 29% gain at the 1 hour, sustained again over 2 hours and 24 hours. And this retains statistical significance. So there was a 29% reduction in average migraine severity in the treatment groups after 1 hour, sustained at 2 hours and for 24 hours after treatment. And pain freedom at 1 hour was 5 times higher in the treatment group compared to sham. The migraine responders, those are the people who had more than a 50% reduction in pain severity, was nearly twice the rate in the stimulation group compared to sham. And so I think that's very promising for a lot of people who've had bad experience with traditional acute medications. So this is the follow-up then, where they looked at a 2-hour protocol. They thought, oh, can we potentially, get better results out of a more prolonged use of it? So again, doing a very similar type of study, but they had more patients, so improved statistical significance, and they looked at a 2-hour. So this one, they recruited 538 patients, again, split 1-to-1 with a sham. And again, recording the visual analog scale and most bothersome symptoms. This is a baseline, 2 hours and 24 hours. Similar inclusion criteria, just maybe a little bit more stringent, making sure it wasn't onset after 50, which should be a red flag anyway. And, exclusion criteria were, again, a little bit more stringent this time around. So maybe difficulty distinguishing migraine attacks from tension type headaches. And that's a difficult discussion to have in the clinic. I think a lot of my patients maybe have a common parlance, colloquially, they think of something as a migraine, but maybe it doesn't fit the ICHD-3 criteria. So that can be actually very difficult to screen. So that presents a challenge for the study. But these are the people who have more than 15 headache days per month excluded. So that's my chronic migraine population. I have only maybe a handful of episodic migraineurs in my clinic, unless they've improved with the medicine I give them. And so I would say maybe that's not as generalizable to a neurology clinic. And the other issue is here, they excluded people who've had a change in their migraine prophylaxis in the past 3 months. So that would be most people in my practice. But I still think it's important to limit the study group. So this study looked at percentage of pain freedom at 2 hours, and then the resolution of the most bothersome symptom. Like I mentioned, that could be anything to the patient. So that's whether it's the nausea or the light sensitivity, vertigo or something like that. Secondary endpoints, looking at reduction in the severity at 2 hours, how many people have sustained pain freedom, at 24 hours, which is pretty relevant. And then the resolution of all migraine-associated symptoms. So who's really feeling good after this? So here are some data on the pain freedom and most bothersome symptom. As you can see, again, sham still has pretty significant contribution with placebo there. But still a pretty significant statistical gain. And so there were 7.2% higher rates of pain freedom among the people at 2 hours in the stimulation group compared to sham. 14.1%, had resolution of their most bothersome symptom compared to sham. And sustained pain freedom at 24 hours was, significantly higher, so this, and pain relief rather, in the stimulation group. The people who had a good response, they had 14.3% reduction of migraine pain severity. And so all of these met nice statistical significance with that large group that they recruited. The people who were lucky with complete resolution of all their nausea, vomiting, light and sound sensitivity, 8.4% higher in the stim group. So just for comparison, you can't really compare apples to oranges, and the trials are all different. They all slightly define everything slightly differently. But if you're looking at sumatriptan naproxen combination pill, which is out there, or just sumatriptan or naproxen alone, these are kind of comparable to some of the results of these other traditional medicines. Then it comes to like side effects. So, if we are thinking about triptans, you'd have things like chest tightness, sedation, a weird feeling. Sometimes I think it's like a angina almost, but generally well tolerated. So for these stimulators, they can cause some, more discomfort locally. So some people really just don't like the sensation of a TENS machine. It feels like it's a buzz or a paresthesia, and it can give them a little bit of sore skin locally or make them feel dizzy, tired. Maybe they're getting some radiation into the jaw or elsewhere. But in general, it's like pretty comparable to the sham, except for forehead discomfort and the nausea and vomiting. So next up, we're moving away from the acute, which is kind of the as-needed paradigm, and we're looking at a preventive. So using it on a regular basis to try to stop your headache. So this one was, again, looking at the Cefaly for this purpose. It was a bit of a smaller study, 67 patients enrolled. And again, double-blind, randomized, and sham-controlled. So in this case, they're comparing the TRUCE intervention, which is 20 minutes daily for 3 months, versus a sham stimulation. And this one was looked at in Belgium. So again, male or female, 18 to 65, you had to have episodic migraine under the 15 per month mark, and having at least 2 attacks per month. People who are excluded from this are those who had any migraine preventive in the past 3 months. So they're not contaminated with other treatment. And then people who were refractory, they have tried 3, adequate drug trials before of a good duration, 2 to 3 months, and adequate therapeutic dose. Anybody with medication overuse headache, frequent chronic tension type headaches in addition, or other kind of severe neurologic and psychiatric disorders, which again, kind of stretches the generalizability to my clinic for sure. In this study, the primary endpoint was the number of people who have a 50% or more reduction in headache days, and that includes all days of migraine and other types. Secondary endpoints were looking at the intake, the use of acute medications, how many discrete migraine days or attacks they had, and the reduce in the number of headache days. So for the study data, they had 67 subjects, like I mentioned. Only 59 subjects actually completed the study. Change in the monthly migraine days, it's, minus 2.1 versus 0.3, actually maybe increased in the sham a little bit. Just kind of going over the statistical cutoff for significance. So it's not quite meeting it. The 50% response rate, however, did do quite well. So, maybe not migraine specifically reducing, but when we look at it at a different way, reduction in the other types of headaches that come along. Many people think that, they spend a lot of time kind of parsing their headaches out. I have 6 types of headaches. This one's the migraine, this one's the tension, this one's whatever. I mean, pragmatically speaking, I think of it more like a continuum. And so, sometimes it's hard to tell. Like, you may not think you're photosensitive, but you're preferring to lay in a dark room, So I think it can be hard to identify those migraine days. So I think for me, a useful surrogate is really just the 50% reduction in headache days. I think that's useful. Migraine medication use was reduced by over a third in the treatment group. And there was also kind of 29% reduction overall in any kind of headache days. Oh, there we go. So how do people actually like it? I guess that's the most important thing because we're talking about adherence and giving people options. So there was a good survey where they looked at all the patients who had been refilling their adhesive things over time and had purchased a subscription to it. And then they asked them all to participate. And like any kind of survey, I think they got like a 56% response rate because not many people want to write in, especially if they're doing well. And so what they found was that out of all the people using the device that wrote back, not all of them use it to treat acutely. Like there were a chunk that were mostly using it for prevention only. But I would say 88.6% is pretty good that they're using it for acute in addition to preventive. 42.6% of people believe that they were reducing their use of acute medications as a result, which is nice. Fewer interactions with other things. Maybe you're saving some money in the long run, which we'll get to in a second. And then there were the people who said, no, I don't use it to treat attacks, only preventive. And so parsing them down, why didn't they like to use it? Again, I think it goes back to that adverse side effects slide. Some people don't like the sensation on the skin. It makes it feel sore or a buzzing, weird feeling. Some people just feel it doesn't help for acute, but it is still useful as a preventive for them. And so I think, in general, it seems well tolerated and people do like it. So onto the cost. And I think this is the barrier for a lot of people, to be honest. If you look at Amazon, you can find this on sale. It has a little bit of a coupon code. And you'll have to buy those replacement pads like we talked about. They each are good for about 20 applications. And it's a very comparable price if you go onto the actual Cefaly website, which is probably the better place to purchase it, to be honest. The nice thing about it is it has a 90-day money-back guarantee. I'm not paid by these people, so I can say it pretty nicely. I think it's a great option because it gives people who are hesitant to commit a big chunk of cash, to give it a fair shake and to see if it really helps them. So I think that's actually pretty generous. And it is given a 3-year limited warranty. So, if it does fail because of a, manufacturing defect or something, you can get it a replacement easily. So like I mentioned, each electrode is good for 20 uses. So, it's 32 for a replacement pack. What other kind of options do we have? So another one that's available here in Canada is the gammaCore. And if you've been around for a while, you may recognize this is like the new modern version of this. The other one was kind of a circular one with 2 electrodes, and it was a blue one. So this is in a contrast to the Cefaly, which was kind of an external transcutaneous stimulator working on the forehead. This is a non-invasive vagal nerve stimulator. So the vagus is the 10th nerve. And this one's acting on your neck. And so it's targeting that cervical portion. And so it has actually quite a few indications. They're very good at studying it for use in different types of primary headache disorders. So it's primarily indicated, I would say, for preventive and acute use in migraine in both adolescents and adult patients. But it also has some demonstrated use for cluster. And so I've had some cluster patients who have tried everything. They've done the verapamil, the lithium, maybe dipping into psilocybin in an unregistered way. And, I found that maybe this was a useful tool for them to avoid additional medication side effects. Other types of unusual cousins of cluster, things like hemicrania continua or paroxysmal hemicrania, There's also some data to support use in these people too. The Cefaly, you can kind of just purchase yourself over the internet. This one, you may require a letter of authorization. And it doesn't necessarily have to be from a specialist or a neurologist. It can be your family doctor, a nurse practitioner, a nurse, just physiotherapist even, just someone who kind of has that expertise and they feel comfortable to go through the contraindications and everything with you and decide if it's a good fit for you. This device, it is private sale, but the company provides some training to you at the initial purpose, just to make sure you're using it correctly and that you get a good outcome. And then, if you need support as you go, you can always contact the patient support system and they'll help you with any questions. So how is it used? This is a little bit different from the Cefaly. So where Cefaly was 60 to 120 minutes, you're going to start this one as soon as you feel the pain, 2-minute stimulations, and you do 2 in a row. Then you wait 20 minutes. If you're still having a headache, that's unfortunate. Hopefully you got rid of it already. But you do the same thing again. So a 2-minute run, you take a pause, you do another 2 minutes, and then you're kind of in a refractory period. You got to wait 2 hours. Of note, it's important that you apply the gel. So there's a conductive gel that you actually have to apply to your neck for the electrodes each time. You wouldn't want to put it directly. It won't work as well. And treatment 3, so again, you waited your 2 hours. If you're still getting a little bit of rebound or it didn't happen, that you're feeling better, then you repeat the course one more time. In the preventive, it's kind of similar, but you're taking this on a daily basis and you're just, spacing it out throughout the day. So first thing when you wake up, you're going to do 2-minute stimulations. You're going to wait 4 to 6 hours to do, by midday or so, 2 more stimulations. And then again, before bed, you can do it again. So people that should not be using this one, similar to Cefaly, any kind of implanted device. But again, it kind of harkens back to like where exactly you're stimulating. In these people, you don't want anything like a pacemaker, any implanted metal devices, plates, screws, anything in your neck in the area, cochlear implants, hearing aids, etc. The other thing is you can't use other devices at the same time. So, you don't want to be on your cell phone with one hand while you're stimulating on the other, just to make sure. And safety and efficacy, probably may be safe, but we just don't have the safety data to recommend it for people who have other significant medical issues. So this would be uncontrolled hypertension, arrhythmias, either fast or slow. Adolescent patients who have congenital cardiac issues. I mean, probably the likelihood of causing an arrhythmia is low, but, it's still something to consider and be cautious with. People who have a lot of coronary artery disease, atherosclerosis, angina, or issues like that. People who have already undergone vagotomy, where they've severed the nerve. So, it may not even be an effective option for them. Kids, unfortunately, under 12, we don't have the data to support the use just yet. And as always, it's going to be difficult to do any kind of registered trials in pregnant women. So I would say I would avoid that, for now. So what exactly is vagus nerve stimulation? I think it sounds kind of weird. The vagus nerve, if you think of all your cranial nerves, you got 12 of them. And we talked about trigeminal already, which is the 3 branches each side of your face. Vagus is the 10th nerve. And it's called vagus because it is a wanderer, like a vagrant. So it goes all around your body. It innervates all sorts of different organs, tissues, and has a lot of different functions. It does brain, heart, regulating your heart rate, your digestive system, moving your bowels along. And that probably is the basis for a lot of the GI symptoms of things you experience with migraine, the change in the motility of the gut, the nausea, and the vomiting. So it's a key part of parasympathetic nervous system. And if you think back, we have fight and flight, which is the sympathetic, and you have the rest and digest, which is the parasympathetic. And so these two systems are constantly at balance in each other in your body. And when they're out of whack, they can cause a lot of bizarre symptoms. So vagus nerve stimulation has already been demonstrated to be useful in a couple of different important conditions. Headache, migraine cluster, and others like we talked about. It's useful for patients with epilepsy in select cases, refractory depression, and they may be using stimulators at different sites, even in the arm. And it's being investigated for use in bowel and motility issues, gastroparesis, ileus, things like that. So, it is an interesting target for therapy and it has a lot of potential uses for different conditions. So the gammaCore, how does it work? Again, I'm going to give you that line that, it's a mysterious mechanism and we haven't quite elucidated everything. But it's thought to kind of modulate that same trigeminal nucleus center that we talked about. And what's interesting is even just stimulating on one side, it's actually affecting changes bilaterally. The brain has a lot of kind of bilateral connections that affect both halves of your brain. So the first thought is that, we have this nucleus in the pons. This is kind of the ball sitting underneath your brain, right on top of the medulla and the brainstem. And there's an area there called nucleus tractus solitarius or solitarii. And so we think that perhaps this is feeding into the vagus nerve, and that then goes back down to the trigeminal complex. Another way is perhaps it's coming up through that nucleus, going to the parahippocampal gyrus. So you think of like the brain in section, you got the areas that curl underneath where your memories happen. And there's an adjacent area which helps to process pain, tied to memory. And then that goes back down to the medulla. So maybe taking the long route home. And then we have top-down modulation. So this is thinking about higher centers in your brain. The hypothalamus is a center that does everything from day-night cycle, thermoregulation. It has a lot of different regulatory functions. Homeostasis, which is that balance inside your body. And so, we're thinking there's also indirect connections modulated through there. So, we'll go quickly over some of the kind of interesting pieces of evidence. Again, if there's any interest, we can do a more academic talk and look at the specific studies. Vagal nerve stimulation was able to kind of stop the effect of, we take the dura, which is the lining of the brain in rats, and then we would give them a noxious stimulus, whether it's heat or chemical, and also just study how it works in rats that have migraines. And when you gave them the vagus nerve stimulation, it actually slowed the rate of that firing and stopped that signal. Interestingly, we have other studies where we look at, giving people a painful heat stimulus and measuring, the amount of tears that are produced, which sounds pretty horrific when you say it out loud. And by doing vagus nerve stimulation, you're actually able to stop the reflex of lacrimation. And that's a brainstem mediated thing through the trigeminal complex. People who are familiar with aura, the kind of basis of that on the brain is something called cortical spreading depression. And we can measure the electrical activity spreading over your brain and how it burns out, and that causes some of the symptoms of aura. So they were able to raise the threshold that you trigger in aura and also stop the spread of it going farther, which could progress to other more, severe symptoms of aura. And so vagus nerve stimulation was able to attenuate that. The other method they think it works is actually more like neurohumoral. So it's not just all electricity, there's a lot of chemicals at play here. And so it's thought to have an anti-inflammatory effect, by inhibiting cytokines, which are some of your inflammatory chemicals, the messengers. Again, this is a generalizability from a rat study, but there's some good basis that it's conserved in people too. The other one is, linking the two kind of together. So the aura basis, the spreading depression, as it spreads over the brain, it leaves kind of in its wake a nasty chemical soup of inflammation. And so it's thought that, they're able to measure this actually with micropipetting. And, vagus nerve stimulation reduces the magnitude of that release. So onto the study data. So the first study for gammaCore is PRESTO, looking at acute treatment. And so this is, again, a multi-center study, but this one's focused in Italy. They recruited 248 patients, and they were randomized either to the stimulator or to sham within 20 minutes of their headache onset. And then they were told that they could repeat the treatment again if they weren't better in a quarter of an hour. And so there were 3 4-week periods. They had a run-in period where they're just, recording all their headaches in their diary to get a good baseline. Then a double-blind period where they actually did the sham or the vagal nerve stimulator, followed by an open-label period where they knew what was going on and they were able to use the actual stimulator, even if they're in the placebo group. So primary endpoints for this one, they were concerned with, they want pain freedom for the first migraine attack. So what proportion of the patients were free from their headache at 120 minutes and they were not using any kind of triptan or NSAID or anything. Secondary endpoints, how was it sustained pain freedom at 30 and 60 minutes, and then relief, which could just be any reduction in the severity at 30, 60, and 120 minutes. They looked at the mean percentage change in pain score across these times, and also the absence of, the associated migraine features, like we talked about before. So now we're kind of upping the ante. We are including some of our elders, which is always good to see because we don't have a lot of quality data on people up to 75 and beyond. These are people who have, typical migraine, episodic or chronic, with or without aura, and very comparable to the other studies. People who are excluded, again, people with psychiatric or cognitive disorders, another significant pain disorder, substance use. I think these are all reasonable exclusions because they can confound the result, but like I mentioned, limits generalizability a bit. So onto the data. So this is looking at the number of patients who are achieving that pain freedom at the time after treatment. They reached significance for reduction in pain severity at 30 and 60 minutes, but with the initial analysis, unfortunately, did not reach statistical significance on the first pass at 2 hours. But what they did do was they reanalyzed the data, and using a multiple comparisons measure, they were actually able to determine that it was still a significant sustained benefit at 2 hours. But again, this is a post hoc analysis. So it would probably bear repeating, the study with greater statistical power to confirm it. So for the preventive study data, this is now onto the premium 2. And this is looking at, how good is this vagal nerve stimulator for preventing headaches on a regular basis. Again, multi-center, double-blind, randomized sham-controlled trial, looking at patients with or without aura. So they initially recruited 336 patients, but they wanted to make sure about adherence. And so with a modified intention to treat protocol, they included only the people who were adherent to the treatment at least 66% of the time, which I think is fair. But again, that speaks to what are the reasons in a true intention to treat? What are the reasons why people are not continuing? So I think that's important to consider. So again, this study had a 4-week diary run-in period where they get a good idea of people's baseline amount of headaches. And then the patients were randomized to receive either the actual stimulator or a sham over a 12-week double-blind period. So for this one, we already covered the treatment protocol. It's 3 sessions spaced out equally throughout the day of 2 stimulations, each for 2 minutes, waking, midday, and before sleep. And for the sake of the protocol, it had to be delivered on the same side of the neck, usually on the same side where you have the most pain. Primary endpoints included the change in the number of migraine days from the run-in period that they were measuring that diary to the last 4 weeks of the double-blind period. They also looked at other key endpoints like 50% responder rate for migraine, the mean change in the number of headache days, and also, reducing the amount of medication use. People included in this one, episodic or chronic. They had to make sure that they weren't over 50 at the time of onset, which, like I mentioned, is a red flag. And people who were excluded, people who are already on 2 migraine preventive therapies, receiving ongoing Botox or CGRP, monoclonal antibodies, and people who have had a previous diagnosis of medication overuse headache, which, I would struggle to recruit patients from my clinic, I think, and any preceding history or suspicion of a secondary headache disorder. So in this slide, we're looking at the change in the number of migraine days from that run-in period to the last 4 weeks of the 12-week period. And you can see that there was a difference, 0.83 days fewer, and not quite statistically significant. The issue with this study was that it happened during the pandemic. And so they weren't able to reach their statistical significance for the primary outcome due to a lack of, recruiting patients and maintaining them in the study. So they had to terminate it earlier, unfortunately, and that affected the statistical power. And there's a lot of talk in medicine about re-examining p-values and intervals and what it truly means. And on the other flip side of this issue, you can size a study with 10,000 patients and prove the most minuscule difference is statistically significant. So I think we're trying to look at other ways statistically as well. So I think it's an encouraging result that still shows, some improvement, but perhaps it needs to be reanalyzed with greater statistical power. So in contrast to this, I think there are also other endpoints where there were significant differences that suggest that it is a very useful therapy. So for instance, this is the 50% responder rate for all headache days. And, you're looking at the people who received the stimulator. It's 44.8% as opposed to 26.81%, and so I think that's pretty significant. Odds ratio of 2.22, so that means you're 2 times more likely to have a positive response, reach the threshold. In this one, this is the change in the number of headache days, all types of headaches, whether it's migraine or otherwise. And again, statistically significant difference. And I think this is important to note. Sometimes these numbers seem a little small, but you're looking at episodic migraineurs. So the difference of a day or two can be a huge difference for your life, for productivity, for working, even presenteeism when you're at work and you're still not feeling your best. So I think it's an important difference. This is looking at the medication use. Again, significant reduction. However, it didn't meet a statistical threshold. And another important way of looking at this is the impact on disability and quality of life. So we measure this a number of different ways, and these scales, all have their own difficulties and limitations. But for now, I think we're stuck with HIT6 and MIDAS, for better or worse, for insurance purposes and things. And with the HIT6 score, again, significant reduction there. With the migraine disability score, which we commonly use, also showing a good change that reached statistical threshold. So what are the side effects? Listed in the monograph, probably the most common are things like discomfort at the site of application, similar to the Cefaly. You may get a little bit of skin irritation or redness. It may kind of hurt in the area where you apply it, but usually it's pretty mild. Sometimes it can even radiate into the teeth. For some individuals, they reported this. Muscle twitching or contractions makes sense. I mean, it's an electrical stimulator and you can kind of hijack the mechanism there. That's usually only when you're applying the actual stimulation. It's not like it's going to keep twitching typically. Some people actually feel worse with headache. And that's interestingly listed as a side effect of every oral medication is potentially headache. And Botox injection even often causes a worsening of headache. So that's not anything specific. Some people feel a little dizzy or, paresthesias, pins and needles feeling where you apply the device. But again, that makes sense because you're stimulating it. So these side effects, they typically resolve very quickly. And it's important to note that throughout the whole of all the trials, no really serious device-related events were found, and nothing was significantly really greater than placebo. So just looking at the adverse events, it doesn't list them specifically here, but what you can see is that when you compare it to the sham, the numbers are fairly comparable for most things. So how are you going to get it? So RSK Medical is the company that's licensed to distribute electrocore for electrocore in Canada. And I've left it up here if you want to take a peek. You can either reach them by telephone, they've got an email or a website which you can visit. Like I mentioned before, you would require a letter of authorization. How much does it cost? So, you can buy a couple different options. For a 31-day starter kit, it's about $655. And so you can use up to 32-minute stimulations daily. You do have to continue to replace it on a monthly basis, so it is a subscription service. The other issue is that you could, stock up. If you find it's effective and you want to get a little bit of a price benefit, you can lock in for 93 days and it ends up being $975 Canadian. So the issue is it's not covered by public payers, which is a significant barrier to many people here in Ontario, ODSP or who are applying to the EAP program for various issues. But if you have a private payer, like one of the many insurance companies through your work or benefits, it might be possible. Every plan is a little bit different, and it probably depends on what your adjuster ate for breakfast. But I would say reach out to them and see if they're willing to consider it. You can always ask your provider for a letter of support. So providers, how do you go about helping your patient to get this? So there's a very easy and convenient prescribing process. You can find it online at their website, like I listed. And there's also a form, and it's easy to enter it into your EMR, and you can auto-populate everything. So you just kind of indicate whether you'd like to do the 93 or 31-day trial kind of thing. And you can also, if you prefer, to write a little letter of support indicating for insurance. So a quick overview of the things that unfortunately are not available in the North. There are a couple. but we'll focus on two. Neurivio is a really interesting one. And so this device is an armband that's controlled from your smartphone, and you just wear it on your arm. It's a remote electrical neuromodulator, which is also targeting the vagus nerve, but a branch that's innervating elsewhere. And so, this can be used for acute treatment of migraine with or without aura in adolescents or older. Again, this one requires prescription, but you do administer it yourself at home. And you would put it on right at the onset of the attack. And it's been shown to be useful for acute decrease in migraine-related pain. Currently available in US. eNeura is another very interesting one, and I think this technology has a lot of potential for applications outside of migraine. It's a transcranial magnetic stimulator. And so you may have seen some interesting setups with all the weird coils and everything. You go to a psychiatrist or a physiatrist's office, and they will affix the coil somewhere to your head and pulse you with magnetic waves. And the magnets actually induce an electrical signal in your brain. And so it's a kind of way of getting deep past the skull without actually inserting any electrodes or anything. It can be used as a preventive, 4 pulses of this on a twice-a-day basis, or as an acute medication treatment rather, with 3 pulses during a single attack. So again, requires a prescription, and it's a subscription service where you return the device or charge it. And again, you would administer this to yourself at home. Only available in the States for now, but perhaps they may expand in the future. Just a quick overview I kind of mentioned already. Using the magnets to induce an electrical current blocks the cortical spreading depression, which is a commonality to the mechanisms we already discussed. Kind of calms down that trigeminal complex and its connections to the thalamus, which we talked about already. It stops the spread of cortical spreading depression, which is the aura type symptom. And also modulates those corticothalamic reverberations, those loops. And so all of this kind of feeds in to calm down that brainstem where we think the migraine comes from. So very interesting that all these devices share a lot of common pathways, but they're looking at modulating the brain and the neuraxis at different entry points. So it's kind of an exciting time with all these devices emerging. And I think it's given a lot of hope to people who, are eager to see how it evolves because they're eager to try therapies that are alternative to what has not worked for them so far. So in summary, I think these non-invasive neurostimulators for migraine, they may be useful for both acute and preventive treatment of migraine, which is nice. It's a non-medication option, which I think is useful for those who are hoping to avoid systemic effects and interactions, or maybe have contraindications from other medical conditions. And, it's not an either or situation, like this is complementary to existing therapies. So you can, take it in conjunction with your other modalities if you're not quite happy with how things are coming along. So it can be used with or without oral medications, injections like Botox or CGRP mAbs. It's safe and well tolerated. And there are a few contraindications to use, like unless you have some sort of implanted device or certain medical conditions like we talked about. And that's why I think it's kind of useful. Access may be limited in some areas, okay? And of course, I think the initial startup cost of it represents a barrier to many. But you kind of have to think about the long game too. If you are sparing yourself a lot of acute medication use, this may actually potentially save you money in the long run. But you'll have to sit down and crunch the numbers. So with that, I want to thank you for your attention, and I'll turn it back to Ashley. Maybe we'll take some questions from the audience.